Welcome to the final webinar in our series, Improving Individual Practice. Although systems can be designed to improve the quality and safety of healthcare, a disproportionately large number of errors and failures have been shown to be due to a small minority of healthcare workers. This is an example of the Pareto principle, which states that 80% of errors come from 20% of practitioners. Good systems can support better individual performance, but without personal development, individual practice can be a source of error. So as well as improving systems, we need to develop individual practice to improve effectiveness, safety and patient experience. Improvement at an individual level is essentially based on learning, but this isn't simply about acquiring knowledge. It also implies an ability to demonstrate that knowledge through the skill of applying the knowledge in practice, and also the attitudes that lead to these skills being used consistently in day-to-day practice. In this webinar, I'll discuss two models, a model of practice and a model of competence. These will help us to understand the causes of good or poor practice. I will also discuss how quality improvement techniques can be used to improve individual practice and how this can be incorporated into the appraisal process for doctors, nurses and other healthcare professionals. The scope and nature of clinical practice is neatly summarised by Tim Norfolk's RDMP model. The model describes practice in terms of relationship, diagnostics, management, and professionalism. In the model, relationship with patients, relatives and carers, professionals or even members of the public is central to clinical work. Relationship depends on good communication skills and other attributes such as empathy, which leads to trust. Diagnostics refers to gathering, interpreting and prioritising information to decision making. This includes the diagnostic process, but also more widely to decisions we make in day-to-day practice. The cognitive processes at each stage of the diagnostic journey determine the accuracy and safety of our decision making. Management is primarily about how effectively we tackle work process and tasks, how efficiently and reliably we carry out our responsibilities, and this includes how we process administrative activities such as dealing with prescriptions, test results and correspondence, or how we conduct a consultation efficiently, and how we deal with multiple, sometimes conflicting priorities. Management is also about monitoring ourselves effectively, maintaining both our performance and our health. Finally, professionalism is the glue that binds relationship, diagnostics and management together. It defines our commitment to best practice and emphasises how we show respect for people, acting responsibly and demonstrating ethical and moral behaviour. In the Skype model, skills and knowledge form the bedrock of competence, but their application can be affected by other internal factors such as attitudes, personality and health, past factors such as personal or professional history, or external factors such as our relationships, resources available and our responsibilities in the work or non-work environment. Improvement implies that we assess our strengths and weaknesses in a systematic way. These models, RDMP and Skype, enable us to consider our strengths and weaknesses more broadly, and thus to build on our strengths and address our weaknesses. A range of methods have been used to evaluate quality improvement interventions in primary care. These can vary in terms of the rigour of the methods used and their ability to attribute improvement to the intervention being proposed. Clinical audit and quality improvement projects can be used to evaluate improvement initiatives, and these should be within the scope of practitioners. More rigorous studies require support from academic teams with expertise in these methods. Studies can range in design from randomised controlled trials to other types of experimental methods. Improvement interventions are complex, and they're often multiple rather than single. They are pragmatic, so that real-world designs are called for. Improvement often involves a series of interventions, including education, reminders, audit and feedback or other measures. These vary in content, intensity or timing between different intervention sites, so that it's not always clear which components of the black box of the intervention are effective. In order to understand how or why an intervention works, it's often necessary to use methods such as surveys or qualitative interviews, focus groups, documentary analysis, observational or ethnographic methods. It may also be necessary to combine quantitative and qualitative methods, for example using case studies, or to work with participants to design the evaluation using action research methods. Quality improvement methods themselves can also be used to evaluate improvement, which adds to the complexities of improvement evaluations. Quality improvement projects can be effectively used to improve individual performance, and the description of quality improvement projects should include the following headings listed on the template. We show an example of a quality improvement project using the template provided. Thank you for listening. If you'd like to follow our work or contact us, please use the following details.